Well, good morning, everyone, and welcome today. And thank you for joining us today for this World AIDS Day event here at the Maryland School of Public Health. And so I'd like to thank all the people who are here in the room with us, as well as all those who are joining us virtually this morning or this afternoon, this evening, wherever they are. Thank you all for being here. As you know, the theme or the title for our World AIDS Day this year is Leave No One Behind, New Strategies for the Global HIV Response. So we're really happy for you that you're able to join us, and we're hopeful that you'll learn a lot of new things from our speakers as well as from our discussants. And I think we will also hopefully discuss together how what we're learning and what we're doing can help inform the strategies till we really can get to the end of AIDS as a public health threat in this country and around the world. In order to get things started, I'm very honored to hand over the podium to Dean Linda Freed, who's the Dean of the Columbia Mailman School of Public Health, a great supporter of ICAP and all of our work. So I invite the Dean to make a few comments. Welcome.
Thank you, Wafa, and thanks to all of you for what you do every single day in such impactful ways for all of our future. And thanks for joining us today, whether here in person or online from all over the world. Commemorating World AIDS Day is a critically important thing to do and an important tradition here at Columbia's Mailman School of Public Health. And that makes perfect sense. Addressing the global HIV epidemic is one of the great goals of public health, not just addressing it, but solving it, both in the US and around the world. And I am very proud that over the entire course of the HIV epidemic, that we have made it a priority in our work. Over the past 2 decades, ICAP at Columbia University itself has distinguished itself as one of the foremost centers for putting knowledge into public health action in confronting a wide variety of global health threats. First and foremost, of course, the continuing challenge of HIV. ICAP will be celebrating its 20th anniversary next year. It operates via a unique model designed to advance all aspects of public health response, including and centrally the HIV response. It performs cutting-edge research to improve prevention and treatment methods and their implementation. It engages in the design, support, and scale-up of HIV services and works consistently, diligently, and to great effect to make them increasingly accessible to the populations that most need them. ICAP has been at the forefront of measuring progress in the HIV response with the surveys that it has supported, informing the way forward for countries and globally. All of these activities operate together synergistically in hundreds of projects deployed across more than 40 countries to make an ongoing impact in the lives of individuals, families, communities, and nations. This, of course, is all due to the tireless leadership of Wafa, ICAP's founder and director, joined with all of you, her amazing teams of endlessly committed professionals and leaders. Today, as we celebrate the progress that has been made in addressing HIV, there is no question that we celebrate the work of ICAP as well. Thank you all for being here, and I look forward to a very exciting World AIDS Day.
Well, thank you very much, Linda, and I really acknowledge all the support you and your team provide to us day in and day out, and your commitment to ending this pandemic. I'd like to acknowledge we have several people who are joining us today, and I'd like to acknowledge a few that specifically we are joined today by 3 members of this CDC team, and they include Emily Strong, Caitlin Fitzpatrick, and Trisha Akers, who are spending the day with us. And I thank them for joining us for World AIDS Day event. Please stand up. And clearly, all of us at ICAP and all of us here acknowledge, of course, the support and the long-term partnership with the CDC. So your presence means a lot to all the people who are sitting in this room and all the people joining us from around the world. Now, I think World AIDS Day is a very special day, and in many ways, it always means something different to different people. But it is the one day where we come together as a global community to acknowledge first and foremost the gravity of this pandemic. This is very important that we continue to articulate the importance of HIV and that people are getting infected with HIV every day, and many people still don't have access to the best prevention methods as well as to the best treatment methods. And I think that's the reason for the theme of leaving no one behind. I think it also allows us, World AIDS Day always allows us to think, or allows me to reflect on how far we've come. And I think to recall as well all the losses that have occurred over the years from HIV/AIDS, the wonderful people and wonderful all around the world that we've lost to this epidemic, particularly in the early terrible years of the HIV epidemic in this country and around the world. So it's a moment to also remember and reflect on all of the losses, while at the same time acknowledging where we're at and the progress we've made. It's been remarkable, the discoveries that have really transformed HIV from early on as a death sentence to now a chronic disease. People living with HIV can live full and productive lives, and that's a remarkable achievement. We also have made amazing discoveries in terms of prevention of HIV, and we now have tools that are remarkably effective at keeping people living without HIV. And I think this would not have happened without the partnerships, and the word partnerships is very critical. The engagement, the partnerships between researchers, between practitioners, between policymakers, between implementers, and between the community and members of the community, people living with HIV as well as people at risk, and how everybody has come together to really help achieve these achievements that I just mentioned. I think also World AIDS Day always is important because it highlights not only how far we've come, but also where we need to go. And I think most of the conversation today will be about where we need to go. What else do we need to do? Now, going back and reflecting on the history of World AIDS Day and over the years, over the many decades, and actually the first World AIDS Day was designated in 1988. That's a long time ago, and probably before some of you were born here in this room. But I think over the years, the theme for every World AIDS Day has changed over time, and there's usually a theme that's identified by WHO every year. And the theme this year is equalize, meaning, again, in some way, leaving no one behind. But over the years, the World AIDS Day themes have often reflected the priorities that were the imperatives that we all have met over the years. For example, early on, there was an emphasis on communication, to speak about HIV/AIDS, to break the silence about HIV. And then for many years, the themes have evolved to focus on specific populations that were left behind. Sometimes it's been children, sometimes youth, women, and even men, who are very important in the HIV epidemic, have also been prioritized. With World AIDS Day theme in the year 2000 was Men Make a Difference. So the coming together and designation of these themes have been important as milestones along the path to guide us in terms of what we need to do and what we should focus on as a global community. Now, one recurring theme that's always been very prominent has been the issue of stigma and discrimination, which is not going to be a surprise to this audience. And that's been the focus again of World AIDS Day for a variety of years, 2002, 2003, and then again in 2013. But the work in that area, of course, is yet to be finished. There's a huge amount of work that needs to be done in order to overcome stigma and discrimination, and some of that lends itself to the theme of today of leaving no one behind. So as you know, leaving no one behind is an overarching principle that has guided our work at ICAP from day one, and that will continue to guide our work as we move forward. So I'm honored today to have to introduce actually two speakers who are going to talk to you today, and then they'll be joined by two others in the panel discussion. So let me introduce the first speaker. And our first speaker, I'm very honored to present my dear colleague and friend, Jessica Justman. And of course, Jessica, as many of you know, is an infectious disease specialist, global health expert. And she's worked throughout her career with a commitment to really leaving no one behind, whether that was during her career in the South Bronx, where she still works, or in her role as the technical director here at ICAP. She's overseen the development and the strengthening of ICAP's clinical laboratory and training programs, as well as strategic information surveys across the range of global projects. She's also spearheaded a very important CDC-funded project, the population-based HIV impact assessment, the FIA surveys. And these have transformed the HIV global programming by highlighting exactly what's been accomplished in terms of the HIV response in various countries, and also helping to shape the way forward. And just today in Mozambique, as we speak, the results from the Mozambique FIA, the INCIDA results have been released this morning. Jessica also leads the TRACE initiative, which is a project that aims to use HIV recency testing to improve HIV prevention programs and strengthen the precision of HIV infection surveillance systems. And finally, I think Jessica's HIV prevention research is longstanding now for more than 20 years, since the early years in the Bronx. And she's continuing that commitment as part of our research agenda here at ICAP through our ICAP clinical trials unit and Harlem in the Bronx and in Eswatini. So without further ado, I would like to invite Jessica to give her first talk, the first talk, which is entitled, "What Will It Take to Reach HIV Epidemic Control?" Welcome, Jessica.
Okay. Good morning and good afternoon to those of you who are joining us online. You may have seen in today's New England Journal a short piece by Anthony Fauci. If not, I suggest that you take a look at his thoughtful reflections on the field of infectious diseases. He ends this piece by riffing on the baseball manager Yogi Berra's very famous saying, "It ain't over till it's over." And what Dr. Fauci says is, actually, it's never over, at least when it comes to emerging infectious diseases. So with that warning in mind, let's talk about what it will take to end, or at least control, the HIV epidemic. Here's just a brief overview. We're going to review the trajectory of the global HIV epidemic. These are graphs that are well known to many of us, but I think for those of us in the room who are less familiar, I think it's always a great place to sort of anchor the discussion. And we'll talk about different approaches to defining epidemic control. And we'll look at data to find the gaps in epidemic control. These are data that we're using to inform interventions. And then, as Wafa described, we're going to look forward and talk about models of care and new tools. So let's start by looking back. Here's a graph of adult and child deaths due to AIDS over the past 30 years. And the good news, let's see if I can get my... The good news is that AIDS deaths have been declining since about 2005 and have decreased by about 50% in the last 10 years. Unfortunately, the global target of 250,000 deaths, a number that has been calculated to be the necessary number to achieve elimination of HIV, compared to where we actually are right now, that looks like a very hard target to achieve. New infections among adults and children have also been declining, but not by as much of a decline as we just saw with deaths. There has been a 32% decline in new infections since 2010. The plan has been for annual new infections to fall below the target of 500,000 by the year 2020, but instead it was 3 times higher at 1.5 million. So what does HIV epidemic control look like? How will we know when we're there? There is not actually a single agreed upon way to define HIV epidemic control. Here on this slide, we see a few different approaches that are in use, and each have advantages and disadvantages. We're going to talk about 3 of them today, the ones that you see have some color to them. We'll talk about progress towards targets. We'll talk about percentage reductions, and we'll also talk about incidence mortality ratios. And I think in the subsequent slides, we'll get a chance to see a little more of the definitions of each of these. So UNAIDS uses progress towards targets to define epidemic control, and that has really been the centerpiece of the UNAIDS fast track strategy to end the AIDS epidemic by 2030. This is both an infectious disease model and a program. We're going to talk about these numbers, and I know that I'm playing mostly to a home crowd, but in case we do have some students or those of you who are newer to ICAP who are less familiar with these targets, I want to just walk through them very briefly. 90-90-90 calls for having 90% of the people who have HIV becoming aware of their diagnosis. Of those who are aware of their diagnosis, 90% should be on effective treatment. And of those on treatment, 90% should have viral load suppression, achieving control of their infection. So what UNAIDS called for was achieving 90-90-90 globally by the year 2020, and then achieving 95-95-95, those same measures, but at the higher level, by 2030 in order to effectively eliminate HIV. CDC has been focused on the percentage reduction method to define epidemic control, at least when it comes to its initiative for the United States called Ending the HIV Epidemic in the US. And here the CDC has called for reductions in new HIV infections in the United States by 75% in 5 years and by 90% in 10 years. And PEPFAR, which is the President's Emergency Plan for AIDS Relief, the US government program that supports the global HIV response, is using the incidence mortality ratio, and in particular is aiming for an incidence mortality ratio of less than 1. That means the total number of new HIV infections needs to be less than the total number of deaths from all causes among HIV positive individuals. So what does that look like? Well, here is an example from PEPFAR that's looking at incidence and mortality data so that you can see what the ratio is between the two of them. And when you look first on your left at Rwanda, you can see that new infections in blue and total deaths in the HIV population in red have really made tremendous progress. Initially, new infections were very high, but have come down and have practically converged with that red line with the number of deaths. It's almost beneath that line, and that would constitute, from the PEPFAR point of view, true epidemic control. If you look over on your right at the situation in Angola, unfortunately, both new infections, again in blue, and mortality in red have been increasing instead of decreasing. And in fact, new infections have consistently exceeded mortality by about a 2-fold margin. Now, again, just for those few students or other individuals who are less familiar with ICAP, Dean Fried mentioned that ICAP is a leading global health center that works collaboratively at every level of the health system. And ICAP has played a major role in measuring the status of the national HIV epidemics through surveys that have informed the HIV response within countries and globally. The data that we saw before from PEPFAR, some, although not all, but some of that data does draw from the FIA surveys. These are the population-based HIV impact assessments, which have already been mentioned. These are funded by PEPFAR and are large household-based national surveys that ICAP has been implementing since 2014, so now for 8 years. The map here on your right gives you a picture of the locations of the surveys, which countries have conducted 1 survey in blue, which countries have completed 2 surveys in yellow, and Eswatini, the 1 country in pink that has completed 3 surveys. Over the last 8 years now, data collection has been completed for 21 surveys. A 22nd survey is now ongoing in Tanzania. 20 summary sheets have been released, 16 final reports, and I urge you all to take a look at the website where you can gain access to some of the public data sets and other resources. So as new infections are decreasing, at least in some countries, it becomes increasingly important to focus on the gaps. FIA surveys are helping us to identify who's getting left behind. Here, the FIA data clearly show how the percentage of HIV positive men who are aware of their diagnosis, and take a look at the gray bars, it's consistently lower, that percentage, than it is for women in the green bars in every one of the 12 countries that you can see in this chart. So in other words, men are lagging behind women in awareness of their HIV diagnosis. Now, moving from diagnosis to treatment, we can see at least there is some good news, and that is that when it comes to treatment for men at the top and viral load suppression for men in the bottom, really men and women are doing equally well and look very similar. And then here we have from the FIA data, the entire HIV care cascade, where the first lighter green bar in each case shows you awareness of diagnosis. The second one in the middle, a little bit darker, shows you the percent on treatment. And the third one shows you the percent who are virally suppressed. And we're going to see these types of graphs over and over. So I wanted to just make sure that we're all caught up on this. So here, compare the progress with the HIV care cascade among the younger population across the top, defined as between the ages of 15 and 24, compared to the older population. So anybody who's 25 and above is called older in this case. Younger populations are really lagging behind compared to older populations. So the younger populations are getting left behind. But not everything is about gaps. I do want to share these 3-bar graphs that summarizes 10 years of tremendous progress in Eswatini. In 2011, on your left, only 28% of HIV positive adults had viral load suppression, and only 62% were aware of their diagnosis. 5 years later, there was a big increase where 66% of the HIV positive individuals in this country had viral load suppression. And now, in results that were released at the UN General Assembly back in September, and also as part of World AIDS Day today, we can see that 10 years later in Eswatini, 88% of individuals, of adults with HIV have achieved viral load suppression. And you can see that practically 95, 95, 95 for each of these 3 bars. So it's really great news. Let's take a look at what's been happening with children with HIV. And here, this graph is a little bit different. Each bar refers to a different source of data. So we've got FIA data, and then in the middle, data from PEPFAR programs, and then the darkest blue color comes from Spectrum infectious disease models. And this is taking a look at the percentage of children living with HIV who are not on antiretrovirals. So we have to kind of flip our view here. And the red bars show you the average treatment coverage gap across the three different estimates. And let's just look at the bottom line. 48% of children between the ages of 0 and 14 who are living with HIV in these 7 countries were not on antiretroviral treatment between 2016 and 2017. What's happening now? Well, according to UNAIDS, as of 2021, that gap has improved slightly. It's moved from 48% to 44%, but it's still a very substantial treatment gap. And now we'll take a look at what's been happening in the United States with ending the HIV epidemic. As I mentioned, CDC is using the percentage reduction approach and calls for a 75% decrease in new diagnoses and a 90% decrease over 10 years. Well, in 2020, there were 30,000 new HIV diagnoses in the United States. So the goal of getting to less than 10,000 diagnoses by 2025 and 3,000 diagnoses by 2030, I think is going to be very daunting. Just in the interest of time, I did not include a slide for you that shows the care cascade in the United States, but I will give you the punchline, which is that in the United States, only 57% of people living with HIV have achieved viral load suppression. If you remember in Eswatini, it's now 88%. And in the United States, at least as of, it's data from 2019, so before the pandemic, it's 57%. So let's just pause for a moment here and summarize the findings that we've seen from the population level data. Awareness of HIV diagnosis is lower among men than women, indicating a need for testing campaigns focused on men. But prevalence of treatment and viral load suppression are similar for men and women. So once men are aware of their diagnoses, at least in the international settings, they're doing well. Awareness of diagnosis is lower among younger individuals than those who are older. And only half of children living with HIV are on treatment, leading to, and I didn't show you the slide, but of course, lower rates of viral load suppression among diagnosed children. So we've looked at where the gaps are, and we've also seen some impressive progress. These graphs on your left show you 9 countries that are approaching epidemic control. You can see those red and blue lines converging. So what happens as HIV incidence in the general population decreases? Where do we go from here, at least for these countries? Well, it will be increasingly important to focus HIV control on what are called key populations. And this was highlighted in a recent article in JIAS, the Journal of International AIDS Society, about how reductions in HIV incidence are likely to increase the importance of HIV population programs for HIV control in sub-Saharan Africa. And here I've just included for you some data from UNAIDS that points out in 2021, key populations, namely men who have sex with men, people who inject drugs, and transgender women and their sexual partners accounted for 70% of HIV infections globally. Outside of sub-Saharan Africa, key populations account for 94% of new infections. Within sub-Saharan Africa, it's 51%. Where are these gaps? Well, we've mentioned key populations, which are on the right side of the slide, and how this the risk of HIV acquisition as compared to the general population is at least 25 times higher for female sex workers, people who inject drugs, transgender women, gay men, and other men who have sex with men. The other group to focus on are what are called priority populations. And these are segments of the population at especially high risk of HIV based on characteristics such as age and gender. And here really the priority population of note is adolescent girls and young women. Globally, around 5,000 adolescent girls and young women be infected with HIV every week. And in sub-Saharan Africa, 6 of 7 new infections are among the adolescents between 15 and 19 and are among the adolescent girls. We looked at data from THEA surveys. Another kind of survey that ICAP has been very involved in implementing are called biobehavioral surveys that focus on understanding the HIV care cascade among key populations. So here is data from a biobehavioral survey conducted in Zimbabwe in 2019 that used respondent-driven sampling, and maybe we'll save that for later to talk about how respondent-driven sampling works. And we can see that, first of all, what you don't see on the slide is HIV prevalence overall among men who have sex with men in these two urban locations in Zimbabwe, Harare and Bulawayo, was 21%. Among the HIV positive men, 48% were aware of their status. However, after there was a recategorization of those who had a low viral load, indicating that they probably were aware and probably were on treatment, it was 73%. Treatment coverage was good and viral load suppression was good. So as we saw with the earlier results, awareness was the major gap here. And here we have results from a similar biobehavioral survey in Central Asia in the Kyrgyz Republic in 2021, but this time among people who inject drugs. And in the capital city of Bishkek, awareness was quite good, but once you go to other locations within the Republic, awareness is much lower. So again, we see this same theme underscoring the challenges with making people who are infected aware of their diagnosis. So we're going to be talking about new technologies now and tools, but we have to know how to use them, especially if they involve new models of care. Sequin, which stands for the HIV Coverage, Quality, and Impact Learning Network, is accelerating high quality differentiated service delivery, sometimes referred to as DSD. What is DSD? Well, it's health services tailored to fit groups of people, not relying on the earlier public health model, which was pretty much one size fits all. And the goal of DSD is to enhance client outcomes, health system efficiency, and HIV epidemic control. And it's supported by community advocates and is now taking place in 21 African countries. Here's what differentiated service delivery looks like from a view from high up. DSD models of care adjust the how of service delivery according to when, where, what, and who is delivered. Where can be in a community or in a healthcare facility, what can be laboratory tests or psychosocial counseling, who can be healthcare workers or peer supporters, and when can be more frequent versus less frequent. Here's an example of a DSD program that consists of a community client-led ART delivery group or groups in Uganda, which they refer to as CCLAD. And the CCLAD basically functions as a peer support group that provides ART refills. And the details of that are listed here in the slide. And I think I'm going to just keep us moving along. I wanted to show you some pictures of some differentiated service delivery programs. Here's a photograph of a trans health center in South Africa. We have in pink this condom kiosk in Rwanda, and then in the bottom part of the slide, a drop-in center for sex workers in Uganda, all of which is designed to bring healthcare services to the particular key populations and to help meet them where they are at and make this as easy as possible. Those kinds of drop-in centers and kiosks that I just showed you are great for people who are willing to go there, but what about people who are not willing to go there? Well, for those who are less comfortable doing that, online tools such as smartphone apps offer flexibility and privacy while booking HIV services. So that's another example of DSD. And then finally, I wanted to just show you this example of a DSD program for men in South Africa that uses a very sports-oriented approach with a squad manager who trains the coaches, and then coaches who are basically peer navigators who serve to coach newly diagnosed men and men who have returned to care. And then they have very specific goals to see that control over HIV will help them to feel strong and healthy, and they can ultimately live openly and confidently with HIV and no longer need the coaching. So now let's look very briefly at some new tools that are coming for HIV, and we're going to focus on PrEP in a moment. I'm going to just first give you this overview on multi-purpose prevention technologies that do combine pregnancy prevention with sexual health, as well as HIV prevention. So for example, a dual prevention pill that can prevent both pregnancy and HIV, a vaginal ring to do the same thing. There are also non-hormonal vaginal rings with the potential to prevent sexually transmitted infections as well, and a non-hormonal contraceptive fast dissolving insert that can be used on demand. In terms of PrEP, I'd say the really big news has been in the area of long-acting injectable PrEP, and I didn't tell you that PrEP stands for pre-exposure prophylaxis. Cabotegravir is an antiretroviral agent that's been formulated to be given as an injection every 8 weeks. And in a trial that compared cabotegravir given every 8 weeks to daily tenofovir FTC, known as Truvada, what happened was cabotegravir was more effective at preventing new HIV infections. This lower yellow line shows that there were fewer new HIV infections in the cabotegravir group compared to the daily tenofovir group. And this really I'm going to say, was largely driven by the improved adherence that happens when you only need an injection every 8 weeks. So cabotegravir was approved by the US FDA for PrEP just 1 year ago. It feels like a long time ago, but it was really only December of 2021. And now it's been approved in 5 countries. It's in the US, it's in Australia. It's approved in Zimbabwe and Uganda, and as of yesterday, South Africa, which is a really big step. So what are our key takeaways? Well, we talked about the evolution of the HIV epidemic and the progress towards epidemic control. We talked about some ways to measure HIV epidemic control, and these all call for high quality, granular data. The data help us understand the gaps, especially gaps in awareness of diagnosis, which we saw is a real challenge for men, young adults, and key populations, and gaps in treatment, which we saw as a major challenge for children. These are the groups that are getting left behind. We talked about differentiated service, excuse me, and the importance of having this tailored approach instead of the earlier one-size-fits-all public health model of care. And then we talked about new advances in HIV prevention. Woven throughout all of this is a greater appreciation of the need to address health equity. This last mile in the global HIV response will require attention to barriers of existing stigma, discrimination, violence, and lack of human rights that affect key populations. So with that, I will say thank you and give a big thanks to Connor Wright, who gave me a lot of help with these slides. Thank you.
Great, and thank you very much, Jessica. And I'm sure your talk will generate a lot of questions. So I want everybody here in the room and those who are joining us online to please, you can start putting your questions in the Q&A box. Okay, I'll move on now to our second speaker, and it really gives me great pleasure to introduce Professor Laurent Nelson, a friend and a colleague also. So Laurent is an associate professor of nursing, associate dean of global affairs and planetary health at Yale University. He also serves on the Yale Institute of Global Health's Leadership Advisory Committee. He has worked in the United States as well as globally as well. And his work has included research, implementation science work that spans across the globe. He co-founded the Central and West Africa Implementation Science Alliance, COISA, which is a collaboration of implementation scientists and implementing agencies that includes Cameroon, Congo, Ghana, Nigeria, aim to improve HIV outcomes amongst young people, amongst youth in the region. He also leads implementation science efforts to reduce racial disparities in HIV programming in the Caribbean and also in the Black community in Canada. And his work in the United States has focused on interventions to reduce HIV infections and risk amongst Black men who have sex with men in this country. He has received numerous awards, too many for me to run through them all, but maybe I'll mention a couple. Laurent is an elected fellow in the American Academy of Nursing. He's been honored by many professional nursing organizations, and he actually received Excellence Award for HIV prevention from the Association of Nurses in HIV and AIDS Care. Now, I've had the honor of working with Laurent in the HPTN. He with Bob Remian and Chris Bearer, they chair a very important study called HPTN 096, an NIH-funded study that's focusing on HIV prevention amongst Black MSM in the US South. His presentation today will examine reaching men who have sex with men in the US South. Please join me in welcoming Laurent. Thank you.
Thank you. Okay, good morning, everybody. Wafa, thank you for that introduction and for the invitation. It's a pleasure for me to be here as a public health nurse, someone I've done that my entire career, and someone who's led applied public health as a deputy commissioner of public health in Monroe County, New York, Western New York. I want to start by finding something. Sorry. Okay, no problem. All right, so I want to start by, there's two things I think we have to think about when we think about, as we consider how to reach men who have sex with men in the South. This is an image from, I think it was in Nature, maybe it was Science, I should have known that. But it was a cover image for an article by Dr. Sarah Tishkoff, a friend of mine at the University of Pennsylvania. She is a biological anthropologist. She studies genetic variation in humans. Most of that is in Africa because most of the human genetic variation is in Africa. This is just to say that what she and her team have found and others have found for a long time is that what we understand as race, maybe I should say that differently, what is commonly understood to be race is not a biological taxonomy, right? It doesn't map onto the genome the way I think we think it does, because these racial groupings look so distinct. You see people, the skin color looks different, the shape of a lip or eye looks different, so we think that must be sort of natural groupings of people. Well, it's not. It's not a biological taxonomy. What she doesn't suggest what it might be. She doesn't go there. I will suggest what it might be. That it is a social taxonomy, right? It doesn't otherwise map onto what they're finding, but it does make sense that it could be a social taxonomy. So the social taxonomy is in service of a larger issue. This is just sort of describing what Sarah found. This is the image from the article. It's in service of a system which is racism. Right? So it's important to understand, one, that when we think about race, racial groupings, that we're not talking about biological taxonomy, we're talking about a social taxonomy, right? This is just showing that modern humans originated in Africa, and that the differences that we see are because as humans over thousands of years migrated across the planet into different places, then they develop adaptation. So we all kind of look a little bit different, not because we're different species of people, but because over thousands of years, our bodies adapted to the places where we live. So racism is what this social taxonomy serves. It's important for us to also understand that racism is a multidimensional system. It's a social arrangement, right? It's not just me or you being mean to the person next to you because they look a certain way. That's an element of it. That's kind of what we commonly understand or refer to when we talk about racism or racist incident. But it's actually much more complex than that. It is actually the way many societies are organized. It's how we arranged. It's how you know. It's how you know who to give a pass to and who to punish, or how often you punish them. It's how you know who to give privilege to or who gets assigned to receive disadvantage. It's how we know how acceptable it is for some people to be overexposed to risk and other people we prioritize for protection from risk, right? If we think about risk, not just as a person who does something, but risk as the odds of a negative event occurring, right? This arrangement is how we know who to respond to, how quickly, how vigorously, and who we can ignore based on their assignment in the social arrangement. So why is this important? Because when we look at things like disparities in racial coverage for PrEP, this is data that shows overall, as a country, we're still lagging behind. The percentage of overall people who are prescribed PrEP who are eligible for it is about a quarter. But that is driven by the high number of white folks who are on PrEP, 63%. If you compare that to the other two groups in this chart, Hispanic, Latina at 14%, and Blacks at 8%. So what are we looking at here? We're looking at disparities in PrEP coverage based on groupings, but not on biological groupings, right? It's based on social groupings. Because Black, white are not biological categories, they are social categories. They have health consequences because people are exposed to risk based on their assignment in these categories, but they're not by themselves biological categories. This is another slide that is looking at viral suppression rates. The disparities aren't as stark here, but again, you see differences by these groupings. Overall, it's about 2/3. This is from 2019, but the highest percentage of viral suppression among whites, then Hispanic/Latino and Black. This is important because when we understand that these differences that we see are between groups that we have categorized, these social groups that we have categorized, it leads us to understand that what we do about it has to be different, right? I appreciated Dr. Justman's presentation, especially the last few slides when he talked about the DSD, when and where and who and what. Part of what we have to also understand is this concept of political ecology. This is an interdisciplinary field, but it really is a topic area that's concerned with understanding how the environment influences people's health or influences people in general. That there are things that vary from place to place that get influenced by interactions with the physical environment. These could be social and cultural environments, political environments, or economic environments. Those can even vary within a country like the United States. Certainly they vary globally. When we think also about political ecology specifically to health, these are health and health decisions that are shaped by the social, political, and economic environments that are dominant within a specific geographic context. That could be local, could be state, could be nationally. And that the disadvantages, or that this disadvantages some people and privileges other people based on what status they hold in a particular environment. So it could be their legal status. Do they have citizenship or permanent residence? Do they have money or not? Are they a gender status that gets some privilege? Or do they conform to the gender that they're assigned to? Or are they in a particular racial grouping? And that these things generate hardships, which are inequitable impacts of policies on marginalized communities that might lead them to have poor health outcomes. Right, so having a piece of paper that says you're a citizen doesn't automatically repel infections from you, right? That paper is not powerful. But the status it gives you and the way that the world around you responds to you once you have that status is what makes difference, right? It depends on what environment you're in, those interactions. So if we think also about the political ecology of health, hardships, and HIV risk, it really situates hardships within a framework for understanding how health inequities and their impact patterns are produced by larger social and political forces. Produced, very specific word. They don't just emerge. They don't just develop. That these systems produce these patterns. The social groupings, the value we place on them, the ways in which they expose people to risk and other people to, and protect other folks from risk actually produce these patterns. We know that they're gonna happen. So if individual behavioral, let me say this. So these forces operate in particular locations, kind of where, and at particular times, all very important. So then if individual level behavioral characteristics are equal, people are kind of doing the same thing, having sex, not using condoms. Why then do we see HIV incidence differ from place to place? We all kind of, HIV isn't transmitted in a million different ways. There's very few ways to transmit it, but the rates differ so widely and so specifically among particular groups. So why that happened is probably not one particular answer, but there is at least an answer. And that is that the social, cultural, economic, and political processes actually structure opportunities that either support or thwart healthy decisions or exposures. This little maze in the corner, you might have seen this. When I would go to the dentist as a kid, they had these little magazines with puzzles and you would try to figure out how to get there. And almost no matter where you started, like you just couldn't get there. There were these things in the way systematically. So you had to be the right pilgrim, right? Start at the right place to be able to get that prize turkey. And if you weren't, it didn't matter what you did, didn't matter how many times you thought about it, it didn't matter how long you looked at it, it didn't matter. The barriers were predetermined. They were already in place. So we think about this and apply it to the HIV epidemic. Think about race as a system. We think about politics, how they vary from place to place in the US. It doesn't become surprising that we see patterns like what we see here. This is the prevalence of HIV diagnosed in 2019. Out of the 1.2 million people living with HIV at that time, 46% lived in the South, 41% were Black, and 18% were Black MSM, right? If we look at new diagnoses, you see a similar pattern that along the South Atlantic coast and across the Gulf of Mexico is where you see most of the HIV infections, even though that's not where most of the US population lives. But this is not just a story about HIV. This is a story about destruction. So you can look at other diseases and see the same patterns. This is an article that I published with Greg Millett, Chris Beyer, and Tonya Petit in the Annals of Epidemiology. And we looked at things like poverty. This is that, it's too small for you to see on the screen, but rates of poverty, rates of unemployment, that's the purple, rates of uninsured, that's the sort of golden pattern, all takes that same area on the map. Those are the social issues at the top. Across the bottom is syphilis, gonorrhea, diabetes, and heart disease, right? Not HIV. But because the structure is the same, that the ways that the disease is distributed across the country all looks the same patterns. We look particularly at Blacks in the South. So Blacks in the US South had the highest number of new HIV diagnoses compared to all other regions. If you look at that number, that is 19,000 HIV infections in the South. Half of those were among Black people. That is more infection than any other region total. Just Blacks in the South accounted for more HIV infections than all people in the Northeast or the Midwest or the West, right? Stunning that is happening. And if we look specifically at Black MSM, in the South, nearly half of all the total cases of HIV in the South among MSM were among Black MSM. You just heard a few minutes ago about the advantages that we've, as a nation or world or scientific community have developed. Some of these led through HPTN. Look at HPTN 052, the introduction of, we learned that Truvada had efficacy in preventing infection, and also the introduction of rapid home testing. When those things came, we saw that there were decreases in HIV incidence. But most of those decreases, almost all of it, were among white MSM. That's the yellow line. But you would expect it to decrease. When these things are introduced and people use them, that you would expect that incidence would decrease. But if you look at the purple line, the Black MSM, almost unchanged in that same time period. Why? We have treatment as prevention. We have PrEP. We have easier ways to identify cases through home testing. Why don't all the lines go down, right? I think it's because of this. That's still in place. That's what we have to tackle. More discoveries will be wonderful to have if we just want to have more discoveries. But in order for us to have impact, we have to figure out ways to address these. And so I'm sort of talking like a social, I guess I am kind of a social scientist mixed with a clinician. So, but if we're saying, if I'm telling you that geopolitical context is co-implicated in our ability to reach everybody, in our ability to reduce HIV infections, then what do? Right? If we're not a room of politicians or policy people. Has anybody ever heard of Thomas Kuhn? Thomas Kuhn. Thomas Kuhn is a historian. I'm not even sure he's alive. Hope he's alive. He's not, okay. Shout out to Tom. And so I learned about him a long time ago when I was in school. And he studied the history of science. And what they expected was that these scientific advances that we have are linear, that one builds on another and it builds on another, and then you learn more and we get closer and closer to finding answers to things, right? That makes sense. People would expect that, right? Well, what they found is that that's actually not how it has worked, that there are periods in the scientific timeline that don't correspond. So 50 years of doing this, something happened the 51st year. People are doing something differently that don't quite map on what they did 50 years before. And so what he did was realize that science had this sort of normal, I forget what he called it. I think he called it normal science, but it's a way that we sort of agreed that this is how we do things. And people just kind of did it that way until somebody or some group of people said, this ain't working. This doesn't make sense. This doesn't comport with reality. We have to do something different. And they just did something different, right? It wasn't just based on all the science that had been done, because they realized that they were doing it that way because your professor did it, and he trained you and his postdocs, and they trained their students, and they just kind of all did the same thing without thinking about what was the next innovation. So he called these sort of breaks, scientific revolutions. And I think that's what we need now is this scientific revolution. I think WAFA is actually our revolution leader getting us there. I think we have to do it differently. Even if we haven't completely figured out the methods, we got to develop the methods that we can test these things and know how much it works. Because even though we have what's in the middle, prep, we have art, we have testing, we've not yet figured out a way to implement it without leaving so many people behind. And we know who we're leaving behind. Sex workers, key populations, men have sex with men, racialized minority groups. And that means we have to have other types of interventions, social ones, structural ones that do things that typically we don't learn in our epi classes or our medical school classes or nursing school. We have to do them or we'll get the same results every time because those structures are going to stay in place. That's part of what we're trying to do under the leadership of WAFA and Mike Cohen at HBTN. Me, along with Bob Ringan, who's a professor here, and Chris Byer, who's a professor at Duke University, are leading a HBTN study, HBTN 096. And this is a multi-level approach that integrates really two things. Self-determination theory, which I didn't talk about, but it's sort of my thing, what I do, and political ecology, which is saying we have to pay attention to what's happening, not just in the clinical realm, but the social and political realm in particular places. So our intervention has 4 components: culturally responsive intersectional stigma prevention, which is addressing a couple of things: anti-Black racism, HIV stigma, sexual stigma, and healthcare facilities. Peer support, online peer support, a social media intervention, and then health equity, which are local coalitions that are designed to have policy and political impact in the communities where these coalitions are. That if we can do that, that we can change, hopefully, change some of these structures that have been keeping PrEP and art and testing out of reach for Black MSM in general, people in general, but particularly Black MSM. And if we can do that, we can increase testing, increase the uptake of PrEP and among people without HIV, and increase the uptake of art and adherence among Black MSM who are living with HIV. This is just showing us how we had thought through it, that the mechanisms of action is that we can increase multi-level social support, reduce intersectional stigma, and address structural barriers to HIV services, and that can increase an individual's agency. Like the ability for them to get to that turkey. I hate to use that example, such a violent example, but maybe they're gonna rescue the turkey, not kill it. People are motivated. People don't need female sex workers and MSM and Black women. They can do it, but there are these very real obstacles that are in the way. And I think we have to figure out a way to set people free, right? We don't need to tell them what to do. We just need to get the stuff out of the way that's keeping them from being able to live the lives they want to live. So our study is focused in the South. We could have just done a study where we want to test the intervention. We got a lab someplace in New York or New Haven where I live, but that doesn't address the issue. So political ecology is saying that there's something happening in particular places. So we need to be to the places where the issues are happening. So we're doing a study in the South. These are all EHE identified communities. There's 16 communities that we randomized. 8 will be intervention communities and 8 will be standard of care comparison communities. Right now, we started in Dallas, Texas, and Montgomery, Alabama. Next year, we'll be expanding to include Fort Lauderdale, Florida, and New Orleans, Louisiana. Fort Lauderdale will be the intervention community. And this is a trial. This is a large, complicated, cluster community randomized controlled trial because we have to understand whether or not this works. We're testing this hypothesis. We're doing this in collaboration with the Centers for Disease Control that is providing us data on viral suppression in communities. And we're also doing our own data collection to understand the prevalence of PrEP uptake among the Black MSM in the communities where we do the intervention. And I will say, we are even testing some new models because I'm not 100% sure that we have the methods necessary to answer the questions that we need to answer. And so we're using RCT because we know how to do that. But even as we're doing that, we're tinkering around with some other methods to help us understand how then do we modify this as we go along, as we learn more. So if we learn something in 2022, what should we not take advantage of that in our model versus saying, well, in 2018, we came up with this model, so we're going to stick with this, even as reality is telling us that some things aren't working, that the world has changed. We have to be able to adapt to that, and we need models to help us better do that. So we're trying to innovate that as well. And then the last thing I'll say is we're really trying to have some alignment between science and policy. It really was important to us when the End the HIV epidemic strategy was released, initiative was released, and we really tried to design a study that would help the nation advance its policy goals. That's important because a study like this is big and it costs a lot of money. And so science for the sake of science doesn't always align with policy objectives. And so we needed to make a study that would give us important scientific information, but that had the potential to demonstrate impact. Not after 5 years, we have an answer, but no impact. But we need to try to get an answer and generate impact at the same time. And so much of what we're doing aligns with these components: diagnosing, treating, and prevention. We have not gotten to that fourth one, which is about responding. But we think using those first three will get us very close to this. And so finally, where people live matters with respect to if they're situated into these places where they're either rendered overexposed to HIV risk or protected from risk. And it's not just a place, it's who you are in that place. Being Black in some spaces might be protective. Being Black in some places will not be. Being gay in some places will be protective or valued. Being gay in some places absolutely will not be. We need to pay attention to health and health behavior patterns that emerge when we're looking at different municipal contexts. So not just, is this happening in the US, but where in the US is it happening and why is it happening? And what do we do about it in these particular places so that we aren't leaving folks behind? These patterns that we see might indicate underlying social policies and political processes that disadvantage MSM. And we can't shy away from the political part of it. Like we can't ignore it. We'll just be playing ourselves, thinking we're doing something and not doing much at all. Because a lot of what's happening is political, right? Just in, this is my last bullet, but just in Texas, where one of our study sites is, there was a ruling, I think it applies generally to the United States, but there was the district court in Tarrant County, Texas, that said employers could not be required to cover PrEP as part of their insurance packages. So they could opt not to do it, right? That is not a health behavior decision, right? That is a structural decision that political, that is going to impact these rates, right? So we can't be doing this science and pretend like there's not political processes happening that we want to ignore. We have to find ways to do it. We need a revolution and be willing to take what it comes when we do that. And so HIV prevention science needs to test strategies that match the character and magnitude of the problem. We can't tinker around the edges. If the problem is complex and big and scary, we're going to have to do science that's complex and scary and perhaps big. So thank you.
Well, thank you very much, Laurent. Okay, thank you very much, Laurent. I do think you are leading a revolution, and we're all with you in this path. I can't really I can't oversay the importance of the work that Laurent is doing and the other leaders of the study and the work that they're trying to do and the importance of the study that he just described very briefly. It's complex, it's tough, but that's what it will take, is doing the tough work. And I think we've learned that in all of the work that we've done, but I think we need to continue on this path. So thank you, Laurent. I remind everyone, please think of your questions and put in your questions in the Q&A box. I look forward to discussing many of these issues on the panel, but first I'm going to invite you all to watch a very brief video that ICAP has developed that showcases some of our work around the world, particularly in advancing pre-exposure prophylaxis PrEP, which is, as you know, is a crucial component in terms of ending the HIV epidemic. And I think what you'll see is a compilation of excerpts from some videos or a series of videos that we have created and distributed in 6 countries. And the purpose of this was really how to reach the people who really should be aware of PrEP, how to make them aware of PrEP, how to make them less fearful of PrEP, how to make them understand what it takes to go and seek PrEP and to stay on PrEP. So these are videos that were really developed with the goal in mind to reaching the people who need the services and to overcome some of the barriers that Laurent mentioned and Jessica mentioned. Okay, let's watch the video.
PrEP é um método de prevenção contra o HIV que impede que apanhamos infecção no nosso organismo.
O PrEP é tomado. Primeira condição, tem que ser uma pessoa HIV negativa.
Eu ouvi pela primeira vez quando eu vinha receber medicamentos da minha esposa, porque ela é seropositiva e ela toma medicamento. Fiz teste quase 3 vezes e não estava a me acusar, então. Eu quando já comecei a tomar, disse é melhor estar a tomar medicamento do PrEP.
When somebody is HIV positive, you never know because it's not written on somebody's back or somebody's face. So this is something that is in blood, and blood is hidden. So I have encountered in my life people who have lost hope because of HIV. People have died, people who are potential, people who are providing for their families. They have died from HIV/AIDS. I am also, a parent. So if I do not keep myself healthy, then you realize actually I will also be affecting psychologically the child that I'm bringing up. And when I looked at PrEP, I felt, wow, PrEP was a significant prevention. PrEP has really benefited my life because in the month of November last year, I did have a sexual partner, and only to realize actually he had told the condom without me knowing. He said actually he just tested positive for his HIV. I came for PrEP refill and I did the test. He tested and I tested. I was negative and he was positive. And since then, I'm still HIV negative. So to me, PrEP works.
PrEP is an HIV prevention drug. I want to say those that are at high risk of getting HIV, that needs this PrEP, especially are the FSW, the female sex workers. PrEP doesn't prevent pregnancy. It does not prevent STI. PrEP is just for HIV prevention. I would encourage my friends, my close friends, to take PrEP because I know if they are high risk of getting HIV. They need condoms, but they need PrEP to prevent themselves from HIV. They should be determined within them that they want to take PrEP. I want to be on PrEP. I want to be on the safe side.
Mi nombre es Verónica Alveo, tengo 23 años, soy una chica trans, panameña, vivo en la ciudad de Panamá.
Mi nombre es Alison Blanco, soy una mujer trans de 30 años.
Mi nombre es Delvin Simmons y yo soy promotor de PrEP aquí en Panamá.
La PrEP es muy importante para la comunidad porque todas y todos estamos en riesgos. Y la PrEP viene a ser esa respuesta a poder cuidarnos y cuidar a otras personas.
No importa si eres migrante, pues no importa si eres indígena o de cualquier estatus social en la que tú te encuentres, simplemente tienes que considerar que estás en alto riesgo, que estás vulnerable a infectarte de VIH, o si en algún momento has tenido ya alguna infección de transmisión sexual, entonces este es el momento para que puedas iniciar a tomar PrEP, que con una tableta lo que te va a ayudar es prevenir a infectarte del VIH.
Quiero cuidarme a mí.
Sí estoy tomando PrEP y voy a seguirla continuando porque me ha ayudado mucho a sentir que mis encuentros sexuales sean mucho más seguros.
Je suis une personne à risque. Je suis vraiment exposée. Je me tape des partenaires chaque jour. Mais intérieurement, s'il est vraiment porteur du VIH/SIDA, je ne le saurais pas. J'ai entendu parler de la PrEP pour la première fois, c'était un navigateur avec 40 années. Ce que je vous conseillerais, tant que nous sommes vraiment au risque, nous devons prendre la PrEP régulièrement, chaque jour en combinaison avec les préservatifs et les lubrifiants. Comme moi je le fais toujours. J'ai adhéré à la PrEP pour me protéger contre le VIH/SIDA. Et jusqu'à aujourd'hui, je garde mon statut sérologique négatif.
Thank you. Thank you very much, and thanks to our communications team, and thanks to all the teams in the countries that you saw today who really made this happen. So thank you. And you can see the full versions of these videos on our website, as well as also get access to the toolkits that were mentioned in the last slide. So at this point in time, I'd like to invite Jessica and Laurent up front, and also Roshana, please join us. Now, as I've already introduced Laurent and Jessica before, but I'd like to introduce two more panelists who are joining us for the panel discussion. And first of all, online from Tanzania, welcome Nasoro or Sami Said. And Sami is an MSN peer counselor who has vast experience in HIV programming. He's been working with ICAP in Tanzania since 2014, and he's received training in key population-friendly services, PrEP, HIV testing, index elicitation, and testing of sexual partners and social network testing. And he's also done, as well, received training in community-led monitoring, leadership, governance, and organizational development. And with ICAP, he's currently leading the community team and doing an amazing work on reaching peers, identifying, mapping hotspots, providing health education to key populations. And finally, Sami holds a diploma in journalism, radio, TV broadcasting from Musoma Utali College in Tanzania. Welcome, Sami. The second panelist that I'd like to introduce, welcome, Sami. We'd like to introduce, I'm delighted to have with us today, Roshana Red, who's sitting right here. And Roshana is an ICAPer. She's a nurse, a practitioner. She's practicing clinical research on treatment and prevention of STIs and HIV, and on treatment. She's particularly interested in issues related to opioid use disorders, and has been leading work in our Bronx Prevention Center, particularly work related to people who inject drugs. She's a New York native, and she received multiple amazing degrees and accolades, 2 bachelor's of science degrees in biology and nursing from Howard University, Masters of Public Health from George Washington University, another Masters of Science degree in nursing from Vanderbilt University, and in 2014, she completed a doctorate of nursing practice as well. Thank you and congratulations, Roshana. Works at the Bronx Prevention Center, as I mentioned to all of you. She's a site coordinator and also the clinical coordinator for another HPTN study, HPTN 094, a trial that's testing a novel integrated strategy study amongst people who inject drugs here in New York. So I'd like to start with a couple of questions as we wait for questions, and we have microphones here roving around to get your questions, as well as also invite individuals online to submit their questions. But let me start with you, Roshana, and ask you a question. I think you heard from Laron and from Jessica sort of the whole idea of leaving no one behind, and if you can share with us some of, in your experience, particularly in leading the HPTN 094 study in the Bronx and in New York overall, tell us a little bit about what the study's trying to do, and maybe some of the insights you've gained in terms of how to reach this population.
Thank you, Wafa, and hello, everyone. Fabulous talks, Lauren and Jessica. Can you all hear me okay?
I think
a little louder. Is it on? I think that's better. Maybe this way? Better. Yeah. Yes. Okay. So just to give you a little bit of background about the HPTN 094 study, it's a study that was initially launched last summer in 2021. And it's a study that is looking to determine the efficacy of a mobile unit being brought out into the community to provide medication for opioid use disorder, HIV prevention, HIV treatment, hepatitis C referrals, and peer navigation for people who inject drugs and are also diagnosed with opioid use disorder. And the study has been fantastic in that we've been able to reach quite a few people in a little over a year. We made our year mark in June of 2022. And so now we're a little over a year and a half in, and we've enrolled 65 people. Our goal is 90 by June of 2023. And we definitely see that people who inject drugs and who use opioids face stigma that Wafa has spoken about earlier in today's meeting, and often feel that they've been left behind, that they're not seen, that they're not heard, that they're a population that no one cares for. And so in addition to providing clinical services to link participants to care and to treatment, we are faced with the challenge of letting them know that they are seen and that they are heard by not only us as a clinical research team, but also by our community partners. And that's been really important, is during the rollout of the study and throughout the implementation of it, is we've developed these great relationships with partners offering healthcare and social services and housing to better serve the participants and those within the community, so that they don't feel left behind, so that they do feel seen and do feel heard. Excuse me. So while that stigma is definitely there, we hope that our study is offering a little bit of help with that area. Some of the challenges that we have faced along the way have been expected and some have been unexpected. And they're challenges that we've anticipated, and so we've had plans for it. And then there are some where we've had to work on the fly, and we feel like we've done pretty good with it. So going into the study, we knew that we would be faced with folks who are using opioids like heroin. But early on, we realized that there was a game changer. We had to also work with people who injected fentanyl and other drugs that they weren't even aware that they were injecting, like animal tranquilizers, and that caused additional clinical issues that we weren't expecting. And so really early on, we had to develop strategies to educate folks on what was out there, build that trust, because often with stigma comes mistrust. And with the use of peer navigation, which has been stellar in this study, I think a lot of the participant community was able to trust us pretty quickly from the beginning. And that's been huge. And we've been able to link people to treatment. We've been able to educate folks on what's out there so they make better decisions. And we've been able to roll out the study, really well.
Great, thank you very much. And we'll have a chance to dig deeper, but thank you. It's remarkable the work that the team has done, in all honesty, and really trying to address the needs of this population that often is really highly stigmatized. I'm going to now go to Sammy. I hope you can hear me in Tanzania, but I'm wondering if you can, you've been leading this effort in terms of responding to some of the special needs of key populations in Tanzania in particular, and trying to expand services within the country. What are from your perspective, what are the key obstacles that come to mind that stand in the way of achieving epidemic control, what Jessica talked about? What do you think are the issues, the obstacles faced in Tanzania in particular, based on your experience?
Hello. Hello, good morning.
I can't hear you very well. Can you speak up? Or might be the connection also, right? Unfortunately.
Hello, team. Can you hear us?
Yes.
Yes, can hear you. Yes.
Good morning. Yeah, for sharing my experience in working with ICAP in Tanzania. First of all, I want to say before ICAP start to work with us, we had many challenges, including discrimination and stigma from community and health facilities, leading to a border between health facility and beneficiary. This contribute to the raised HIV infection, sexual transmitted disease, and many challenges. This was also a difficult to living situation, as many people had now to hold. We witness, we as a peers, the days of our colleague due to lack of services. But since ICAP has started to work with us as a peer here in Tanzania and in a country, it had also changed a lot of us as a KVP. First of all, I can say that presence or increased awareness about the health issues, especially in terms of HIV/AIDS and also sexual and reproductive health issues. We as a peer volunteers, we help match to other people or to our colleague on demand creation for HIV testing and counseling together with spreading awareness on HIV package, like other my colleagues said before, like a PrEP, condoms, and mat services for periods, cervical cancer and screen for family planning for HUI and female sex workers. Other thing for cooperation with other stakeholders in eliminating of stigma and discrimination toward the people of KVP groups, as ICAP working together with us and other stakeholders like local government, administrations, and other community. And the other thing that's improved to us from we start to work with ICAP, it's about income for us as a peers or as a KVP in Tanzania. They improve income for the people in KVP, especially as a peers, volunteers. Most of them are having employment. We are in employment because of stigma and discrimination through our situation, like KVP. They didn't want to work with us. Their perception is about they can't do this work, they can't do this and this. But through ICAP, they empower us and make us proudly working with the community and succeed somehow. And some our needs, like when we get some salary or some per diem and get something to eat on or to continue to live. This is my little bit experience from ICAP since I started to work with.
Great. Well, thank you very much. Thank you for your insights and particularly on the ground experience. And I know that the program in Tanzania has been particularly adept at really moving the services into the communities. And I think that's necessary and important. I'm going to go to you, Jessica, with a question next is, you talked about the different definitions for, I guess, ending the epidemic or epidemic control. How do you think these should be the implications for reaching key populations of these definitions? I mean, these definitions seem to me to be largely relevant to general population kind of epidemics. Or do you see that it would be tougher to demonstrate reaching epidemic control if we, from the perspective of reaching these for key populations and vulnerable populations in particular?
Thanks for that question. I think it depends on what group is in your lens, I think. I think that when UNAIDS puts out its report, starting with those kind of big global views, that is very much focused on general populations, and it's less clear how well those track towards progress in additional groups. I actually don't really like the term key populations, but it is the term that we are using so that we're all understanding each other. I showed a slide of a biobehavioral survey done in Zimbabwe that measured the HIV care cascade among men who have sex with men. In Zimbabwe, there was another slide I didn't have time to include that also looked at the care cascade among transgender women and genderqueer individuals who had actually a little bit less progress on the care cascade. So it really depends on who is the subject of focus. And I think it's important to make sure that one doesn't assume that the data from general population surveys is telling us what's going on within all segments of a population, because it's not.
Yeah, and I think that's important to keep in mind is the need for specific also population surveys as well. Moving forward, and even the UNAIDS is that you have to really dig deep and disaggregate the data. And I think you did that as well, Laurent, in your talk. We need to go beyond the averages to understand where we need to focus. So that's very helpful. Maybe going to you, Laurent, next. So what are, you've met, you talked to us about the importance of, I guess, developing or doing meaningful science that actually impacts the lives of people and changes policy and so on. What are the impediments to trying to do that? What are the structural impediments to actually do the kind of science, do the kind of research that you described to us, or the type of research that needs to be done? What are the disincentives? What are the incentives?
I've been asked that question before, and normally I turn and say, look at the audience. It is a very diverse audience. I can't say that this time. But at a place like Yale, where I am, like you turn around and you mostly see a room full of white people, right? And that means that if these are the leaders that we're training to go out and conduct science and create policy and oversee practices, they do it through the lens of their lived experience, which is already shaped in a society that is racist and sexist and homophobic and transphobic. And we entrust the people to take what they learn, but still filter it through the lens of their lived experience, which will be limited. And so in many instances, maybe Columbia being the exception, a structural impediment is that our pipeline is skewed, that people end up in the positions of power to make the decisions about what we study, how we study it, what we implement, how it's implemented, who's funded, how much they get, are not the people who understand this, who understand the epidemic from a different perspective, or who have been the ones impacted mostly by it. I think that's a structural impediment, because the science can sound good, and I guess I won't use that example. The science can be good, but some people have to decide whether we approve it or not, or whether we do it or not, right? Or some politician, and who that person is and how they understand the world and how they understand the problem matters. So I think places like this and other folks who are trying to have more diversity, not just amongst the racial groupings or sexual diversity groupings or gender. The impediment right now is we have who we have. And that is changing, slowly but surely that is changing. I think once that changes, I think younger people just have they just don't have the same attachment to these systems that like me and my parents had. Like gender, like they just aren't that into it. Like, I mean, all this stuff, race, they don't get the need for it. And I think if they can keep that, right? Once they get to they'll just start tearing this stuff down. They'll just start getting rid of it. And I think that is the impediment, is that the people who are in it understand the role in a particular way. It just makes sense to them. Even the idea that race, when I try to explain to my students who are offended, when I tell them that they're not born white, they can't understand what that means. How can, like, not that they are resistant, like fundamentally they cannot understand what I mean when I tell them they're not born white. Everything they know about themselves is based on that, right? So they're not gonna unlearn that in my class. They may never unlearn it. They may try, and they may rackle their brains until the day they die. Some might get there, but I think those are like the very serious things that all this is wrapped up in who we think we are and how we understand the world around us. Those are the impediments, but I think we'll get there, and I think it'll be young people, it'll be queer people who
lead the way.
Who lead the way,
Yeah. I think that's what makes us, at least, it makes me sometimes optimistic about the future. Are all the young people of the audience here? Thank you. I'll go back to maybe another questions to Roshana. And I remember you telling me a story about how, taking that van, the big van, beautiful big van with 094 into the community, and how you were received and how that changed over time. Do you mind sharing that anecdote? Yeah.
Absolutely. So Wafa's referring to a story that I told her about when we first launched last summer of 2021. And before study launch, we met with community-based organizations to partner with, and different community stakeholders, and we received all this feedback, and we were so excited, and we bought our big truck, because when I say mobile unit, a lot of people think a Sprinter van. No, it looks like a FedEx truck.
The biggest size for
The
this one.
bigger size, yes. And we rolled our mobile unit into the community, and our first stop was in central Harlem. If you all are familiar with Harlem, it's like the shopping hub area, 125th Street and Lenox Avenue, so really busy. And we pulled up and we jumped out and we were ready with smiles on our faces. And we got a warm welcome, except for a couple of folks who were like, yeah, we don't want you here. And so we were taken aback a little bit, and we had conversations with a couple of the residents who approached us and expressed concern that our mobile unit would draw folks in who injected drugs and used opioids, and that would saturate their community with people that they didn't necessarily want hanging around. And we used that, well, at first we were shocked because we were so excited about this great study and all of the good stuff that it was going to bring. And then we thought about it and we understood their concerns. And so what we did as a team was have an open conversation with them about what the study offered and what the purpose was, and that was to link folks up to treatment. And they understood what we said and took what we said, and we kind of went our ways for a few months. And then about, I want to say maybe 9 months later, so the summer was about to roll around again, we saw one of the residents who led the charge. And she walked up to us, and at first she asked for a mask because we table with the tent and everything, and we gave her a mask. And she said, you know, I really stopped by to tell you all, I thought this wasn't a good idea. And after watching you, I don't know if you saw me watching you, but after watching you, I changed my mind. And I see the work that you all are doing, and you all are doing really good work, and keep it up. And that was, you know, the biggest seal of approval we could get. It's easy to start off with a fan, but it's even more impactful when you have someone who's a little hesitant in the beginning and watch you work and your passion that goes along with it. And our team is so passionate about the work that we do. And for them to change their mind and acknowledge the work that you do, it was great.
It's really beautiful. I mean, even till today, it just takes my breath away. It's just amazing. But it's the hard work, your hard work, and the work of the team that are here in the audience. Thank you for doing that. Jessica, there's a question here that came from the audience about, can you explain how it's possible that there's no gender gap in viral suppression between men and women if men lag behind in awareness of diagnosis? Okay, go for it, Jessica.
Yep, sure. That is really a reflection of the way I displayed the data to you. So if you remember when I was describing the definitions for 90, 90, 90, they are, I'm going to call them conditional percentages. So it's 90% of those who are aware of their diagnosis should be on treatment. And of those who are on treatment, 90% should be virally suppressed. So that's the conditional part of it. If we used an absolute percentage, then we would be comparing it to the total number of people living with HIV. So if we use that absolute percentage, then yes, men would lag behind women in treatment and viral load suppression. But when we use the conditional percentage, that's when they are the same. And I hope that is clear.
Yeah, thank you. So if we just think of in general in a population, that certainly fewer men would be virally suppressed than women when you look at the whole population overall.
But
great.
It's useful to look at it both ways.
Both ways, yes.
Because it gives you different kinds of information. And again, it helps you understand that once at least in the African countries where we have conducted the surveys, once men are aware of their diagnosis, then they do well at getting on treatment and attaining vital suppression.
Thank you. That's great. Questions from the audience, please. Yes, you. Yeah.
Thanks, Hugh. You can hear me, right?
No, I think you can pull your mask down. You're allowed to do so if you're speaking.
Okay. Roshana, this is a question for you, but it's really based on what Laurent challenged us to do. You know, we have excellent ways of measuring drugs in your body. We can take it from tissue, we can take it from your blood. We know how to measure those individual characteristics. The whole political ecology, we don't know so much about how to measure. I know that in 094, you're trying to do other forms of data collection to be able to understand the context in which you're operating. Could you talk a little bit about those? And if you feel like they address a little bit of the measurement, the methodology gap we have in really being able to document the political ecology.
Thank you for that question. So you're right. We definitely test for the different substances in your system, and we have no problems with that. When it comes to asking questions about other components of what participants' experiences, we will administer what's called a behavioral health assessment. And then we also complete ecological assessments. And so the behavioral assessment is what the participants are actually doing versus what they may be telling us or reporting to us. The ecological assessment is giving us an opportunity to provide information that can't be collected from a participant. So that tells us whether there are different things that are happening in the community that might affect a participant's ability to be able to take advantage of the services offered by the study. So an example of that would be an increase in law enforcement, which we saw around this time last year. And so there was this big push, rightfully so, to increase the safety in the subways and on the New York City streets. And with that came a huge presence of law enforcement. And in particular, if you think about Central Harlem being that shopping hub, it was really important to make sure that that area was safe. But our truck was parked about a block away from that area. And so when command centers of police officers rolled up and parked all day, they started cramping our style a little bit. And it hindered the access that we once had to our target population. And it slowed folks from coming to us because, of course, they were fearful of arrest. And so those types of situations, I think, can affect the uptake of services that clinical research can offer. Those things are oftentimes unanticipated when you start a study, and you have to be really flexible and creative in getting around those things. And one of the things that we did was we just talked to people. So we talk to our participants, we talk to people in the target population. Where are you guys hanging out now? We can't ask you to come back and risk arrest, but where are you guys going now? We will follow you. And that's the benefit of having that mobile unit. You can't pick up a building, but you can definitely roll down the street on your wheels. Hope that answers the question.
Thank you. And I think that gets at how do you overcome the blocks in the maze that Laurent was talking about and anticipated. I think I'm told we have. I have what? There's a class waiting to come in. That's okay. So I think this conversation will continue and can continue because we're all going to move preferably from this door here in the corner, and we're up at a reception in Hess Commons. All of you are invited, all our speakers and panelists are invited. Sammy, I wish you were with us. We could invite you to join us, but thank you for joining us from Tanzania. I want to end by thanking everybody who came in today, everybody who joined us online, our speakers, our panelists, and our communications team who did a brilliant job in putting this whole event together. So thank you all. And let's move up to the lobby, the 10th floor, Hess Commons. I'll see you there. Take care.